Hello everyone. Today we're gonna discuss in the neurology some of the important topics. First, we can start with the movement disorders. So, in movement disorder, first we're gonna discuss about the Parkinson. So, Parkinson we know is a neurological syndrome in which we see deficiency of dopamine, the neurotransmitter, and it can be due to degenerative vascular or inflammatory changes that occur in the basal ganglia. And we know dopamine is secreted by substantia nigra pars compacta, and it's involved in both D1 and D2 pathway. D1 is stimulatory, D2 is inhibitory, and they are both in the basal ganglia for cortical function, and it depends on the thalamocortical stimulation. Now we'll not go into pathophysiology right now. We'll take a separate class for that. So what are the drugs that can cause these dopamine decreasing the dopamine and can cause the Parkinson like disease? So we have already studied them. The drugs like neuroleptic agents, haloperidol, chlorpromazine, antiemetics like metchlorpromide, alpha methyl dopa, reserpine, and we can see poisoning from the MPTP and carbon monoxide and cyanide, manganese. These all disrupt the changes in the basal ganglia and cause movement disorders. And some structural lesions can also occur around the basal ganglia, like it can be trauma, tumor, abscess, infarct, and and there can also be post-encephalitic Parkinson's that can also occur. So, what are the main clinical features? We know tremor, which are mainly resting tremor, and there is akinesia or bradykinesia. There is postural instability, and there is rigidity. So, very commonly we use the mnemonic trap. Remember, tremors, rigidity, akinesia, and the postural instability. They also present with very mask-like faces, with no expressions, and they have very reduced movements, the automatic movements. They have a fascinating gait, and they are stooped. They walk stooped. They are a little stooped. Either they walk, once they initiate the movement, it's very difficult for them to stop, and once they stop, it is very difficult for them to initiate. And other diseases that can also imitate Parkinson's can be severe depression, because because there is spontaneous movement is decreased, so it may mimic like Parkinson's. Essential tremors may be mistaken for Parkinson tremor, but essential tremor get controlled when they get decreased with alcohol and they have a family history, and the Parkinson tremor occur at rest. And there can be other diseases like normal pressure hydrocephalus, in which there is triad of dementia, urinary incontinence, and magnetic gait, and with dilated ventricles on head CT. And the ataxia and the gait disturbance can look like Parkinson. And Huntington's disease, also akinesia and chorea is there, so that may also look like Parkinson. But the Huntington people the patients will have positive family history and the dementia. So diagnosis is mainly clinical, and we can identify for any secondary cause causing any ischemic or inflammatory, or any drugs causing it, affecting the basal ganglia. So treatment is because there is an imbalance between dopamine and the anticholinergics, the dopamine and the cholinergic system, that is the acetylcholine neurotransmitter. So when this decreases, its action is unrestricted. It is not balanced by the dopamine. So acetylcholine action increases and there is a cholinergic excess. So we have to increase the dopamine and decrease the this acetylcholine. That is, will give anticholinergics and will give dopamine stimulating drugs or dopamine agonist. So carbidopa and levodopa used in combination are the main that help to stimulate the dopamine receptors, and the dopamine crosses the blood-brain barrier as levodopa, and it acts. Carbidopa prevents the peripheral decarboxylation of the dopamine, and it prevents the decrease in concentration reaching the periphery instead of brain, so it helps preventing the peripheral degradation and more central effect. So that's why they are used in combination. And we can go for COMT inhibitor and seleglene, amantadine. These all are dopamine agonists. And we can also use anticholinergics, benztropine, trihexyphenidyl, to block the stimulation of basal ganglia via acetylcholine. So for drugs, we can use these drugs. So basically, dopamine agonist and inhibiting the dopamine peripheral decarboxylation. We have COMT inhibitors to prevent the peripheral to prevent the degradation. MAO-B inhibitors like seleglene, and we can also use some of the reuptake inhibitors, and so that more of the dopamine is available in the synaptic cleft for action. And bromocriptine and pergolide, they are ergot derivatives, and they cause cardiac toxicity. That's why we don't use it, and we have better drugs than them with less side effects. So carbidopa and levodopa is the best initial therapy, which inhibits the extracerebral dopa decarboxylase and allows more levodopa to reach the CNS. And levodopa is mainly precursor of dopamine. Okay, and carbidopa is protecting levodopa from breakdown in periphery. And the later, what are the complications that can occur with this levodopa and carbidopa therapy include dyskinesia, that is abnormal movement, or akathisia, that is the restlessness, and on and off phenomenon, which is response fluctuation that we can see when there is good amount of drug reaching. So it is an on phenomena, the patient is responding well, but the drug concentration varies, so it's an off phenomena, and we don't get a good feedback from the patient. And management is mainly sustained release of carbidopa and levodopa with the dopamine agonists like seleglene or tolcapone, entacapone. Those are the COMT inhibitors. Or we can restrict the main, other type of drugs which are causing the depletion in dopamine. That also has to be taken care of. And if there is no response to medical therapy, we always can go for surgical therapy, that is pallidotomy, thalamotomy, or deep brain stimulation in the globus pallidus or the subthalamic nucleus. So these are our last resorts if it's refractory to the medical management and it's not being managed in a satisfactory way. So there are some syndromes that are associated with Parkinsonism, like if Parkinsonism with the vertical gaze palsy, that is supranuclear palsy. If Parkinsonism with a very prominent ataxia, that is olivopontocerebellar atrophy. And there is something with Parkinsonism and orthostatic hypotension, that is in multisystem atrophy. Previously this was called as Schrei-Drager syndrome. So just for it can come as a one-liners like supranuclear palsy and the olivopontocerebral atrophy, the multisystem atrophy. So these are Parkinson plus syndromes, we can call them like that. So let's go to the next disease, that is Huntington's chorea. Huntington's disease. Huntington's chorea is a part of it. So it is mainly a genetic degeneration of the brain, and it is in this there will be a gene, that is Huntington gene, located in the chromosome, on the chromosome 4T, and the gene contains CAG trinucleotide repeat expansion that has to be done, that codes for the protein Huntington. Now if there is a mutation in this Huntington gene, that leads to the abnormal cleavage of this Huntington protein, and that interferes with the nuclear mechanism, and that causes the cell death. So mainly I think the spliceosomes are defective when we are there is maturing of mRNA, and so the protein is defective in it, so it won't act, and we can get the clinical symptoms of chorea and behavioral disturbance. It is autosomal dominant, and successive generation tend to have it in earlier age than the previous one. That is called anticipation. You can see that also. Now mainly onset is around 4th or 5th decade of life, and it begins with chorea or some behavioral changes, and chorea change begin as a fidgeting that will progress to sudden movements of trunk and limb. The gait is poorly coordinated, and the memory is usually preserved until very late in the disease, and there is lack of judgment, disinhibition, and inattention. There is a frequent association with depression due to the disease, and dementia can occur later in the disease. And the behavioral change mainly consists of, you'll see personality changes, that is patient will be more irritable, angry, paranoid, depressed, and even go for the antisocial behavior. So to diagnose, we can see the presence of CAG trinucleotide DNA repeat expression, and on CT we will see cerebral atrophy, and there is atrophy of caudate nucleus. So caudate nucleus atrophy also can be seen, and treatment is mainly tetrabenazine. So tetrabenazine helps the movement disorder of Huntington, but it does not reverse or cure the disease process, and death occurs within the 15 to 20 years after the diagnosis. And we can also give clozapine or haloperidol for behavioral changes, and that's all. Now we can come to the next ALS, that is amyotrophic lateral sclerosis. So it is an idiopathic disease. It has both upper motor neuron and lower motor neuron dysfunction or disorder, and both type of symptoms we will see. So they will see muscle weakness, and upper motor neuron loss, cranial nerve palsies, respiratory involvement, and in lower motor neuron destruction. So at the same, but the bowel, bladder, sensory, cognitive, and sexual functions are preserved. So what we can see is dysphagia, difficulty chewing, or decreased gag reflex, dysarthria, difficulty in handling the saliva due to cranial nerve or bulbar palsy. There will be most common cause of death in this case is aspiration pneumonia, the recurrent aspiration pneumonia, because the respiratory muscles are involved and they are paralyzed, and we can see there will be weak cough reflex will be there, and there is also head tosses because the extensor muscle of neck become too weak so that they can keep the head up, and significant spasticity will lead to, because of the upper motor neurons also involved, there will be significant spasticity that cause pain, and both upper and lower motor neuron weakness is the hallmark of the disease, and upper motor will be seen as spasticity and hyperreflexia, lower motor neuron will be seen as wasting, atrophy, fasciculations, tongue atrophy, and the most accurate or confirmatory test is electromyogram. In this case it will show the diffuse axonal disease, and we can see CPK also elevated, and mainly CSF and MRI scans are normal, because there is no infection or inflammatory etiology. And treatment mainly is we can slow down the progression with riluzole. So riluzole inhibits the glutamate release and death occurs. So it prevents the excitotoxicity, neuronal death. So it helps to increase the life expectancy by some years. Death occurs mainly in 3 to 5 years. And for the spasticity, we can give baclofen and tizanidine for the back spasticity. And the ALS, mainly you have to be, ethical questions are main on the issue of withholding of care, that we have to take care, so that we can see in the ethics. So that's all about ALS in short. The next thing is restless leg syndrome that we all see, idiopathic condition. The patient has a sense of creeping and crawling within the legs. There is dysesthesia and there is involuntary movement during the sleep. So it can be because of multiple bruises, by the partner, sleep partner. At the night, the person seems like to know that they have this problem, and it is exacerbated by more sleep deprivation, caffeine, and pregnancy. So it also has association with uremia and iron deficiency and peripheral neuropathy. So there is no diagnostic test. So treatment, we normally give dopamine agonist like tramipaxol, ropinirole, and we also give patient iron supplementation. We do the iron profiling and give iron supplementation because iron deficiency has also been associated with the restless leg syndrome, and it has shown a great improvement in many patients over the time. And we can also give narcotics and benzodiazepines if it's needed, and if the patient is not satisfied with the treatment. And then there is benign essential tremor. So benign essential tremor is mainly idiopathic disorder with an isolated tremor in hands or head both. So essential tremor which is worsened by the caffeine. Essential tremor worsened by the caffeine, beta agonist, and they improve with the alcohol. Improve and worsen. And they are patient will have shaky hands that improve with the 2 to 3 drinks. There is nothing abnormal that we see in the examination, and there is no specific diagnostic test for this disorder. So treatment, we usually give propranolol, and that is the beta blocker. And if there is no response, we go for primidone, alprazolam, clozapine. And if still there is no response, in very rare case or mainly theoretical right now, is thalamotomy. So what I have seen in the neurology OPD mostly, the propranolol or primidone. These are the two drugs that are very commonly used for this. So these were very, in short, our movement disorders that we have discussed in the neurology part, and next we can have in the next video.